and welcome to another Piper Pod. Today we're going to start a brand new series, and this time we're going to look at pharmacology. So pharmacology is one of those ones that you start looking at the start of your career or while you're studying, and then as you move along you learn a few more drugs, you focus mostly on the effects, and you pay very little attention to the overall interaction of the drug. So in our line of work, obviously we work pre-hospital and hospital. There's a lot of differences that you'll pick up, and a lot of responsibility has actually been placed on us given our exposure to pharmacology. So I think it's apt that we have a look at the fundamentals of pharmacology, look at the safety and consideration aspects of it before we move into the true study of different drugs and how they act. So right at the start, we'll talk about what pharmacology is. Now obviously it's pretty simple. It is the study of drugs. Now a drug can be classified as any substance that is intended or used to modify the physiological effects of your body. Now obviously every drug has a desired outcome, a desired effect. That's why it is given, or that's why it is taken. So when we start talking about adverse drug reactions, we can split them up into different categories, mostly associated with whether or not they're expected or unexpected or extremely adverse. So when we say the term side effect, we're dealing with those quantified, predictable side effects that can occur from a drug. So obviously the most common negative side effect is nausea and vomiting. Okay, now when we focus on a negative side effect, we usually call those an adverse effect. Okay, but a side effect can be something that is quantified reaction of the drug that is not its primary purpose. So that's what the term side effect would mean. When we move into allergic reaction, we're mostly looking at the unpredictable allergic reactions. So not if someone feels sick, but when it involves an immune response. Okay, so when it has an histamine and inflammatory response to something that has caused an allergic reaction. And the reason it's mostly unpredictable is because if people know they're allergic to a substance and you don't understand the drug that you're giving well enough, then you could give a drug that has similar properties to someone that has an allergy, and therefore it's not unpredictable, it's just that your knowledge was lacking. So most of the time, hopefully, if we do the right thing and we ask for allergies and we understand our drugs, the allergic reactions we come across is always going to be unpredictable. And then the last one is all about those 1%ers. So I think by now in your career you should well know that not all humans are created equal, and there are unique individuals out there that will have effects to certain drugs that no one else in the population will have. And this generally comes down to hypersensitivity or genetic factors that have these ones. So these are idiosyncratic reactions. We'll refer to adverse effects or effects of drugs that aren't its primary response. Doesn't happen enough to be a well-known side effect, but doesn't really fit in the realms of an allergic reaction. So if someone was to get liver damage from a drug that wasn't well known, wasn't a common side effect, then that would be known as an idiosyncratic reaction. Classic one, it's moving into side effects, which can sometimes happen, but when tramadol first came out onto the market, there was idiosyncratic reactions that people would actually have myocardial infarcts from the administration of tramadol. Now over the years this has happened enough to actually be considered a 1% chance of the side effect or adverse effect to have a heart attack. So that's just an example of what is an idiosyncratic reaction. Other terminology that we'll get into and we'll use throughout the actual module that we're doing at the moment is you have to understand different terminology. So when we say associated with certain drugs, you'll understand what we're talking about. So the term medication toxicity obviously refers to an adverse drug effect at a predictable dose. So once you get up to that dose, usually per kilo, you'll start to have what's known as medication toxicity. Now, lignocaine is probably the most classic one that you'll be associated with the higher realms of medication toxicity. So by itself, 3 milligrams per kilo, that's when we start getting into that toxicity level. Now, from a medication toxicity knowledge, we can start to understand a realm known as a therapeutic index. So a lot of time when you're prescribing drugs, okay, obviously we don't do that very often, but when drugs are prescribed, it's a therapeutic index will essentially tell the individual what's the lowest possible dose that you can give someone in order to expect a therapeutic response, and what is the higher end of safe therapeutic dose that you should give. And then obviously what is that level that gets too close or over that toxic dose area. So it gives you a safety margin. Now, drug interaction is it's a very massive topic, especially with a lot of the drugs that are coming out on the market, and we'll learn later why there's a lot of drug interactions. But obviously that any drug that is metabolized a similar way or has a similar pharmacological response or binds to the same sort of proteins is going to have some form of interaction. Now, a lot of these are predictable because over the years things have come up and information like this is always updated. So they have amazing apps these days that you can type in the list of drugs and it will tell you whether it's a mild, moderate or severe drug interaction. So obviously anything severe you don't give. Now, drug intolerance refers to people that have a very low or a very abnormally low threshold to a pharmacological action for a drug. Now, drug intolerances for the first time giving it they're pretty unpredictable. Now, if someone always takes a certain medication and just takes one pill and then starts vomiting, then it becomes predictable. But most of the time, drug intolerances are those small probabilities that you need to watch out for, because there are certain individuals that have a profound effect to even the smallest therapeutic dose of a particular drug. Now, this is something that's particularly important to tell CFAs. Obviously, their knowledge of drugs is nowhere near as great. So when they're giving drugs and they think their 7.5 milligrams of morphine is absolutely nothing, most of the time, you can argue that that is true, but there are certain individuals that have a drug intolerance, especially to opioids, and they will react quite violently to it. Now, just like drug intolerance, you can have the other end of the spectrum. Now, opioids, again, are absolutely classic for people to have a drug tolerance to. Now, that means it's usually associated with people that take the drug very, very often. You can give huge amounts, well beyond what is considered the therapeutic index, obviously never into toxicity levels, not initially anyway, before they'll actually have a physiological response. Now, that's something that can occur when you're dealing with trying to get someone's pain relief under control. You need to weigh up the amount is given, consider drug tolerance, but always look at those adverse physiological responses to see if you can titrate it towards the patient's response, because it can get tricky. You can't just assume everyone has a tolerance because you haven't given enough time, or there's other factors like distribution or absorption getting in the way of your administration of medication. Now, tetrahydragenic is a class of medications that will cause congenital defects in infants. So whenever you're dealing with women who could be pregnant or are pregnant, you need to be very, very careful for the type of drugs that you're giving, and you need to check their pregnancy index. Now, we're not going to go through the pregnancy index in this one because you can all look that up. So you'll be able to know what class of drug is considered completely unsafe and what is considered safe to give to pregnant women, and quite frankly, the ones that we don't have enough information on. So, so there's a few terminology, and throughout the series we'll top into more, but these ones are terminologies to get your head around the fundamentals of pharmacology. Now, when it's got to naming a certain drug, obviously we have three different classes of name: the chemical, generic, and our brand name. Now, chemical name in the clinical sense is never really going to be used. Okay? The chemical name is something that is used usually before marketing. So it's when the medication is being produced, it's being tested, it will be given a chemical name, so then you can break down the chemical properties to see which ones they'll interact with, what's most likely enzyme activity, that sort of thing. But once it goes to marketing, the chemical name is very, very rarely referred to by anybody apart from those that are producing the drug. So the one that should be focused on the most is our generic one. So this is the official approved name that is given to the active ingredient of the drug. Now, the beautiful thing about generic names is they will always stay the same, regardless of how many companies jump in and try to make their own better version of the particular drug. So generic name, like metoprolol, for example, that's the chemical name. Doesn't matter how many different brands come out of metoprolol, it will always be called that and will always have that written in it. So when you are referring to medication, especially medications that you are giving or medications that people are on, you should always aim to refer to it in the generic name because it stops confusion. Now, if you're looking at a drug box and you're reading MIMS, or you're reading any official drug book, the easiest way to tell the difference between the generic and the brand name is the generic name will always be written in lowercase. So they do not have capitals within them. Whereas a brand name will always have capitals. Okay, easy way to remember because people are trying to brand it, so they're trying to make their item look more attractive, so they give it a big uppercase letters throughout in order to make it stand out. Okay, so that's the difference. Now from there we can also group the drugs in certain classes. Now it's very simple to make the mistake that you think that all benzodiazepines, for example, are the same because they're all within the same class, but you need to be very, very careful when looking at something's class name because whilst true, they are all benzodiazepines, for example, there is a fundamental difference between certain ones that you can give. Okay, so they will have different effects on the actual body. Okay, so if we look at diazepam, it's used mostly to treat anxiety, or mostly, I said, it's used to treat other things, whereas temazepam is often used for sedation or insomnia. Okay, so whilst they're both benzos, they can be used for different sort of things. Alright, let's move on to the absolute guts of pharmacology, and that is looking at the difference between pharmacokinetics and pharmacodynamics. Now, the easiest way to think of these two particular words, because I know they get thrown around a lot and people don't quite know what they mean, they think they overlap a lot, is pharmacokinetics is looking at what the body does to the drug. So how the body alters and moves the drug around. Whereas pharmacodynamics is looking at what the drug does to the body. And that's the difference. Now, with this, you have to keep in mind there is no such thing as a safe drug. Okay, when you're administering drugs, you need to consider the potential side effects, adverse effects that could occur, and always consider the possibility of an allergic reaction, which is obviously the big one. So we'll start looking at our pharmacokinetics. Now, pharmacokinetics, as I mentioned, it's what the body does to the drug. It can be broken up into four main groups of processes, if you will, and they can fit in the acronym ADME. So absorption, distribution, metabolism, and excretion. All these things fit under pharmacokinetics, and we'll find that a lot of them overlap and complement one another, but generally speaking, it's the four things that you see that fit within the realms of pharmacokinetics, and most of the time it goes through in that order. Now, distribution and metabolism will back and forth one another quite quite regularly, depending on the drug, but they'll always start with absorption and will always end with excretion. So straight up, let's have a look at absorption. So different drugs will be given different ways. And now there's a reason for that, and there's a reason they're marketed that way, and it's got to do with how they're absorbed and what's the intended response for absorption. So oral is the most common way of giving medications. And now obviously you work in some wards, you'll think that it's not, that IV is the way to go, but across the board, as far as drugs are given, oral is the most common way. And it's absorbed by the gut. Now, when I say gut, it's mostly the intestine that absorbs it. Now, oral itself is the only thing that is subject to first pass metabolism. And oral mostly is the one, and profoundly mostly, is the one that has an altered bioavailability because of this first pass metabolism. So what first pass metabolism is you've got to think of the drug as every other nutrient that we eat. So as soon as a nutrient or anything passes through the small intestine, it is immediately soaked up into the hepatic portal circulatory system and delivered straight to the liver. Once in the liver, it is broken down. So first pass metabolism occurs. Now the reason that is slightly different within pharmacokinetics to other metabolism is because it only happens when we're dealing with oral absorption, and it's often just referred to as your first pass effects. So sometimes the first pass effect does start metabolizing. Obviously it goes through some aspect of metabolism within the liver, which is why it changes its bioavailability. Okay, and I'll mention more about bioavailability later on. So just understand that that's the case with oral. But when we move into buccal, so obviously under the tongue, in the cheeks, inhalants, then we're looking about being absorbed directly into the bloodstream. So buccal, obviously picked up in the mouth. Inhalant, very large surface area within the lungs, and it's mostly associated with effects on the lungs. Okay, if we're ever giving anything via an inhalant primarily, then it's based on effects in the drugs. Now injections, straight into the bloodstream. IV, obviously 100% straight in the bloodstream, doesn't have to go to the liver, it's 100% bioavailable. So is subcutaneous and muscle. The difference is obviously how rapidly they are absorbed. IM injections absorb faster than subcutaneous. Now topical has to travel through the dermis in order to get to the bloodstream. Now rectal, believe it or not, you'd think that it would be the same as oral because it's going to the intestine, but this time it's obviously going just to the large intestine, so it doesn't go to our first pass metabolism, and its absorption is very unpredictable because depending on the state, pathological state, or the state of the person that is receiving it, it may have altered blood or increased inflammation within the bowel, meaning absorption is going to be drastically slowed down, a build-up of mucus, which means absorption is probably not going to happen, and a lot of other variables. That means that rectal, unless the drug is designed like a suppository, like glycerol suppository that's designed to work in that environment, is not going to be very reliable in its absorption. So that's absorption. So when we talk about bioavailability, what it means, remember, it's only subject to oral in a classic sense. Now, I'm not going to get too in depth at this stage, but bioavailability alteration is classically affected with oral medication. Now what it means is how much as a percentage of the drug that you physically administer is going to reach the bloodstream and to more an extent reach the target area. Okay, there's certain drugs that will get into the bloodstream a certain way, but will have a reduced bioavailability by the time it gets to the target zone itself. Now when we look at the difference between intravenous and oral, intravenous doesn't go through the liver, so it's 100% bioavailable to the blood. Oral doses will pass through, So 70% is metabolized by the liver at the start, then 30% of it is bioavailable. Now the reason that's important, because if you want the equivalency of dose, IV versus oral, you'll have to do equations to figure it out. So if it's 30%, you're looking at about 3 times the amount before you get the equivalency effect of the IV dose. And that's all the term bioavailability means, is how much of a percentage after it goes through first pass metabolism and in a lot of case metabolism after distribution is going to be available to the target area. Right, let's move on to distribution. So once it gets in, once it's absorbed, the end goal is for it to be in the blood. It to become part of the circulation to obviously transport around the body to be utilized. Now this is highly susceptible and affected by how much blood supply is actually getting to the area of absorption and the area of target as well. It's also got a lot to do with how the drug itself is physically made. So if it's something known as lipophilic versus hydrophilic, lipophilic is going to be more readily distributed to the cells, because things that are lipophilic means they love fats, they can pass through lipid membranes easily, whereas hydrophilic can't. Hydrophilic are often pulled in directions based on osmolarity draw and things like that, so they don't have the same free ability to pass into the target areas, which is often the cells. Now, on top of that, a lot of drugs will bind to your proteins. Now, the main protein that it binds to is our good old friend albumin. Now, it does bind to obviously a lot of the other proteins in there, but majority of them, it will bind to albumin. Now, the wonderful thing about protein-bound drugs is if the drug, or a percentage of the drug that's in the bloodstream, isn't bound to the albumin, then that part is active. So that will be utilized by the body, it will move on, it will activate receptors, it will do what the drug's supposed to do. And then when that part is no longer effective, obviously you have a concentration shift, which will cause the bound drugs to break off and become freeform, active. So this protein-bound drugs will actually have a much longer half-life and a much longer therapeutic effect on someone compared to those that are just free-flowing through the blood, ready to be soaked up. So that's the massive advantage of having protein-bound drugs, and a lot of them, like I said, will bind to the albumin itself, which is lucky because it's the most abundant protein in our circulation. Now, when we get to classic metabolism, not first pass metabolism, this is when it's floating around the bloodstream in its form. It will go to mostly the liver. Now, there are other organs that will go through metabolism, and sometimes drugs are metabolized by the red blood cells themselves or enzymes floating in the blood, but mostly it goes into the liver and goes through a process known as biotransformation. Now, when it moves into biotransformation, considering if your body is perfectly designed for that drug, of course, then it will often alter its chemical form. So it will change things from water soluble to fat soluble, making it more readily absorbable. Now, most of the drugs, once it gets to the metabolism, most drugs, not most of the drug, but most drugs in general, when it gets to the liver, will actually become inactive. So bound to the protein or broken down so it's no longer in effect. So drugs that you give IV will be in effect in the bloodstream. Once it goes through the liver, it will start to get inactivated. Now, when that happens, a lot of the drug will be broken down into things known as metabolites. Now, it's these metabolites that actually go through the process of excretion. Now, excretion is mostly done by the kidneys. Okay, so excretion is mostly done by the kidneys, and you excrete most of your drugs within urine. But obviously your bowel, your respiratory, sweat, and obviously other fluid can also excrete the drug, but most of the time the metabolites will be excreted through the kidney and through the proximal and the distal tubules is where this excretion and reabsorption of drugs will actually occur. So from there, obviously kidney failure and kidney function plays a huge role in how drugs are going to be excreted from the body. And it's something that we can monitor, and it's something that will be put into account, especially if you're working in hospitals, of how much of a drug will be given to a person. Now, the most classic blood tests available for testing someone's urine function is creatine and blood urea nitrogen levels themselves. Now, the unfortunate thing is kidney failure has to be almost half what it should be before these levels will start showing up. But when the serum level of creatine increases, then you start to look at renal failure being in effect. Now, obviously creatine levels are higher in males, especially young fit males or males with a lot of muscle mass, and significantly lower in the aging population. So just certain things to take into account. But if we do a test known as creatine clearance, then that is the most sensitive test that is available for renal function, and it gives us what's known as the glomerulus filtration rate, or at least an estimate of the glomerulus filtration rate. So normally speaking, you should have about 80 to 120 mils per minute, which is a normal creatine clearance level. That's normal. So if you have a normal creatine clearance, then you get a normal amount of drugs. If your creatine clearance is sitting between 30 and 40, then most of the time, things that are excreted by the kidney, you should only have half the amount of drug, because it's going to last twice as long before it is excreted. And if you get less than 30 creatine clearance, then you should be having a quarter or a further half of the original dose in there, because it's going to last 4 times as long within the body. So it's all got to do with how long this drug is going to be active within the body before it can be excreted through the kidneys. So as a general rule of thumb, the creatine clearance is used to test your estimated glomerulus filtration rate. Now, normal is above 90. If you get below 60, start thinking about a loss in renal function and start looking at how to reduce or alter drug doses, things like that. Now, whilst I do not expect this will be something that comes into play when you're sitting in Coltana about to give paracetamol to someone who has a headache, it is something that you need to consider if you're looking at advancing your careers to a more diverse population. Now, something that always plays an effect in your consideration is a drug's half-life. Now, a measured drug's half-life, or a known drug half-life, is always taken into account in order to maintain serum levels. That's why certain antibiotics are given 3 times a day versus 4 times a day. It's because of their known half-life. Now, any drug that has a very short half-life is obviously going to have to be given quite regularly in order to maintain the same effect. Now, different routes of administration will obviously alter the half-life of a particular drug, given the steps it has to go through before it's active in the bloodstream. Now, half-life means how long it takes for half of the therapeutic dose to be metabolized and excreted. So this is taking into account someone that has a normal glomerulus filtration rate, and obviously if anyone has an alter, the half-life would be much, much longer. Now, generally speaking, it takes around 4 to 5 half-lives, however long they are, for a drug to be considered eliminated. So if a drug has a half-life of 4 hours, then you're looking at 16-20 hours before the drug is fully out of the system. Now, there are some drugs that have half-lives of days, just to keep that in mind. So the idea is whilst the drug is still within the therapeutic index for its action, it will still be active in the body for that long or that many multiples of half-lives. So as soon as the half-life level falls below that therapeutic index, then you're going to need to give another dose. And always consider how much has been given to the person and how long it's going to last within them. And if there's a recommendation of 3 times a day versus 4 times a day, it's for a reason. If you give more, then you're going to move out of the therapeutic index, or more likely to move out of the therapeutic index, which means you're not going to increase the benefits of the drug, but you're just going to increase the probability of side effects. That's what it means. Okay, that is pharmacokinetics done. So we'll move on to pharmacodynamics. A lot shorter because I'm not going to go into a lot of detail with pharmacodynamics, because when we start talking about classes of drugs, that's where pharmacodynamics will really come in. So pharmacodynamics looks at, as I mentioned, what the drug does to the body. Now, all drugs are associated in altering existing cellular or chemical functions. They are not responsible for creating new cellular functions or doing something that the body couldn't already do itself under different circumstances. So the most common way that drugs work in the body is they chemically bound to receptors. Now, the receptors don't have to be neurotransmitters, but any receptor site or any base plate that can be bound to is how drugs work. Now, there's only a very few drugs out there that work differently. The easiest way to think of receptor and drug relationship is to have a look at it as a lock and key. So a receptor is your lock and the drug coming along is the key. So the actions of a drug will be dictated by what receptors it's designed to react on, and therefore what receptors it will not react on, and something known as affinity to that receptor site. If the drug has a really good affinity to a receptor site, it's going to have the strongest response for that receptor. Now, obviously there are drugs that can connect that do not have perfect affinity but partial affinity. So they will have a reduced effect, or this is often where side effects come into play because it stimulates a different receptor site of similar properties but not obviously exactly the same. So it will react to that receptor site and you'll get a response. It's how drug interactions and everything like that works. Okay? This is what's happening when the drug binds to the protein. So if you're given 2, 3, 4 drugs to someone and they all bind to albumin, then there's going to be competition. And the one that has the most affinity will be bound, therefore will work the way it's supposed to, and the rest will have that drug interaction. Now, if the drug doesn't react to a particular receptor site, then it's obviously going to have no effect. This is why we can have drugs that have sympathetic responses versus parasympathetic responses, why certain antibiotics will work on a antibacterial wall versus moving into the bacteria and working on the DNA itself. It's why we have so many different types of drugs and how they react within the body, because of how they respond to different receptor sites. Now, like I said, I'm not going to get too much into it, so I'm going to stop and move on. Otherwise, this will keep going much, much longer than it already is. Now, simply put, things that we need to know about a drug that binds to these receptors is they are designed to mimic a physiological activity of our body's chemistry. So like I said, they don't do something that's something in our body or something that is normal within body functions could do. Okay, that's what drugs do. Now, based on their response, they are either called an agonist or an antagonist. So an agonist refers to a drug binding to a receptor and then stimulating some sort of an effect. Okay, so they're an agonist. So they are making some sort of physiological action. They're an agonist. Now, if the drug binds to a receptor and it blocks a physiological action, then it's called an antagonist. And that's the difference. So agonist gives you an effect, an antagonist will block that effect. Okay, so that is introduction to pharmacology in a nutshell. Now, there are a lot of these concepts you've gone over, but before we move on to more complex things, we'll need to look at the fundamentals, the safety aspects of medications, what governs us with medications, and then we can move on into the minutiae of different drug classes. So until next time, take care.